Hi, everyone. Today our topic is ART options on the horizon and how they're going to transform your practice in the near and long-term future. But first, where are we today with HIV treatment? I remember when I was a resident, how people used to die, right? We had bad, suboptimal treatment. People used to be happy that we had ACT. Luckily, since then, we've had a lot more treatment, a lot better, safer treatment, and more effective. So you know that we have a lot of different drugs. The drugs that we've used from the start, nucleoside reverse transcriptase inhibitor, and then the non-nucleoside NNRTIs. Then we had protease inhibitors that really changed, actually, probably the face of HIV because people were willing and able to get a cocktail of drugs. And the latest set of recommendations, if you look at the guidelines, pretty much everybody, the recommendation is to start on integrase-based regimen along with 2 or 1 nucleoside reverse transcriptase inhibitors. So we'll talk a little bit about that. So tell me, Sarah, what do you think about the options now and the guidelines stating that pretty much integrase inhibitor based regimens are recommended for everybody? What do you think about that? Is that good to have just one class as the recommended class?
Yeah, that's a great question. I think, it's evolved just in the last few years where other classes have been taken off the list of initial recommended regimens, but I think it's for good reason. INSTIs are all of the first-line regimens are now contain INSTIs. They have such a high barrier to resistance, so effective, even, with patients with slightly imperfect adherence.
Right. I think it's very ironic, like you said, INSTIs have so much advantages, but when you hear people talking about switch therapies, going back to PIs or going back to NNRTIs to avoid, weight gain with INSTI, I just find it like so ironic that, we make advances and then we say, no, they're not perfect. Let's try to go back and see what happened. So, as you're aware, we talked about integrase inhibitors as being like the basis of all recommended treatment now. But the question remains actually, are we good with 2 drugs? How about dolutegravir 3TC, right? I mean, it is amazing actually that it's working as well as it is. I think it performed very well in studies. And unless people have very, very high viral load, or you don't have a genotype yet, right? You don't want to take a chance and prescribe it. Do you use 2 drugs?
Yeah, absolutely. And more, I think I was initially a skeptic and wanted to wait for the post-marketing and real world experience with dolutegravir 3TC. We saw so many failures with dolutegravir monotherapy in terms of acquired resistance and other complications. And I was skeptical at first, but the data really is holding up. And, the consequences of continuing abacavir in our patients who are on abacavir 3TC and dolutegravir for those who have other risk factors for cardiovascular disease. In particular, those patients, I'm starting to think more about taking them off the abacavir and continuing the dolutegravir and 3TC alone. And then I think the data for in rapid start of dolutegravir 3TC is surprising as well. With all the caveats that you mentioned, we shouldn't be using it prior to a genotype in case of NRTI or INSTI resistance, if in the very high viral loads or in patients with Hep B co-infection. But even in the study looking at dolutegravir 3TC for rapid start, only a very small number of patients had to discontinue it for those reasons. And so it may even be an option for rapid start in the future as well.
So speaking of rapid start, is that something you implemented for most patients?
Yeah, so it's something we're working on, but I think the implementation has been harder. In terms of when patients come in for their first visit, we are starting right away that first day, but the time from the diagnosis in the community to getting them into the clinic is the part where we're struggling to really implement the rapid start component.
Yeah, I can tell you. I mean, same here in Cleveland. we've had a little bit of a hard time implementing it widely on everybody. And it depends on clinicians, right? Some people are more into that's it, first day, and ready to go. Sometimes patients are not willing the first day. Sometimes they're just so overwhelmed. They need to come back. It could be a week later, but they need to come back to talk to you and think about it. So you're right. It's easy, in theory, we know the data is good, but it's something that some people or some providers need a little bit more experience with it before they widely implement it.
Yeah, absolutely. I think I always try to remind my trainees that even though the data supports rapid start, it doesn't mean that we have to. And so oftentimes we're waiting for insurance approval. We really need to make sure that the patient is ready to start, that they're on board with starting before really pushing them to start on that first visit, because a lot of times they're still assimilating so much information on that first visit.
Sure. And tell me what are you doing about long acting? So, as you know now, at least we have one option that's FDA approved, cabotegravir rilpivirine. It's not ideal yet, right? It's the first step of, I think, a lot of good choices for our patients, right? It has to be given IM, which means for now, at least, people have to come to clinic to get it. It's every 4 weeks, even though down the road, every 8 weeks may be a good option, but for now it's every 4. So how many of your patients said, yes, I'm sick of taking one pill. I'm willing to come for IM injections that hurt every 4 weeks to the clinic. I'm interested. What's the uptake in your clinic?
Yeah, sure. So we were a clinical trial site for the Atlas and Flare studies. And so because we were recruiting patients early on for injectable therapy, our patients knew about it. It spread by word of mouth. So there's actually a lot more interest. It surprised all of us as providers. So we are offering it to subsets of patients, those who are really, really describe the pill fatigue, who are really worried about the stigma of unintentional disclosure of somebody finding their medication. But it's been hard to implement, as you mentioned. The patients on trial have been getting it without problem, but in real world, the approval process has been really, really slow. In fact, we have one patient in the process. We don't have anybody on long-acting therapy outside of clinical trial yet, even though there's a lot of interest among patients. How has it been for you?
Well, so in Cleveland, as you recall, it was approved January 21. So we were busy with COVID and telling people, in February, Ohio shut down. So we were telling people don't come to clinic. So it wasn't the ideal time for that drug to be approved. But nonetheless, I think now that things are slowing down in terms of COVID, and we went back to see people virtual, no more virtual, actually face-to-face. More and more of my patients are coming to me and saying, I saw an ad, or I have a friend who's on the monthly, and I have, like you mentioned, the same reaction, but you're doing well. Yeah. I think pill fatigue is more common than we think. Absolutely. Because patients, mainly those who had HIV for a long time, they're happy taking one pill one a day, but it doesn't mean they don't want better options. So I've been surprised with people coming to me and saying, can I have that injectable? And I explain to them, you have to come every 4 weeks. There is plus minus 7 days usually, but still you have to come. Yeah. They're fine. And so far the retention, once you start them, they like it and they continue to do it. So even though it's IM, it may hurt, not as much as I think benzathine penicillin for syphilis. They're not complaining that it hurts that much. So people are willing to come back. Yeah. And I can only see what happened when it's every 8 weeks or with other drugs, like every 6 months doing something. I think it's really, the uptake has been better. Take COVID away. At least the last 6 months, better than we all thought. Yeah. And people like it.
Absolutely. And as you mentioned, I think if it's approved for every 8 weeks, we're going to see even higher uptake.